Okay, let's dive straight into this explainer and uncover the actual truth behind one of the most misunderstood winter illnesses out there. If you've ever been hit with a chest cough that just absolutely refuses to quit, or if you're a healthcare professional navigating yet another chaotic winter season, well, this one is for you. We're going to look closely at acute bronchitis, break down exactly what is happening inside the body, and clear up some major medical misconceptions. We have all heard this dramatic plea, right? A patient sitting there holding a tissue full of yellow sputum after 3 sleepless nights of violent, chest-rattling coughing. Or hey, maybe you've been that patient yourself. Every single winter, clinics are just packed with this exact scenario. It feels severe, it looks alarming, and our immediate, completely understandable instinct is to ask for some heavy-hitting prescription to just make it go away. But as we're going to see, the best, most evidence-based approach is actually quite different from what most people expect. So, here is the roadmap for our explainer. We'll be hitting the classic winter cough, defining acute bronchitis, tracking the 3 stages of the cough, learning how to spot when it's not bronchitis, uncovering the truth about antibiotics, and wrapping up with prevention. Section 1, the classic winter cough. Let's look at how this familiar scenario builds. When someone presents with a relentless cough, total exhaustion, and colored mucus, it kicks off a high-stakes clinical investigation. You see, the clinician's real job isn't just slapping a cough label on it. It's about embarking on an investigation to rule out serious mimics, things like early pneumonia, congestive heart failure, tuberculosis, asthma, or even lung cancer. Acute bronchitis might seem straightforward on the surface, but it really teaches us one of the absolute most important habits in respiratory medicine. You have to treat the patient, not the color of the sputum. Moving to Section 2. What is acute bronchitis? Let's get our definition straight. At its core, this is an acute inflammatory condition of the bronchial mucosa. It happens in a previously healthy bronchial tree where the bronchi suddenly become swollen, congested, and hypersecretory, which makes a harsh cough the absolute dominant symptom. Now, the key word here is acute. This isn't a chronic, long-term structural issue. It develops rapidly over a few days, usually right on the heels of a viral upper respiratory infection, and generally resolves completely without leaving any permanent damage. Now, get this, 50 to 90% of these cases are triggered by viruses. And we're not just talking influenza, rhinovirus, and coronavirus, but also RSV, adenovirus, and enterovirus. Bacteria are actually way less common culprits, and when they are involved, they're usually atypical organisms like Mycoplasma pneumonia or Chlamydia pneumonia. Non-infectious triggers like tobacco smoke or cold air can also make things worse. This is why routine sputum cultures usually aren't helpful. They mostly just grow colonizing organisms from your upper airway that aren't actually causing the problem. If you imagine your airways as an irritable, deeply inflamed tree, it starts to make sense. That burning, retrosternal discomfort you feel behind your breastbone, that is just the tree trying to forcefully clear out mucus and heal. Pathologically speaking, your bronchial mucosa is edematous and hyperemic. Basically, it's swollen and red with a ton of increased blood flow. You've got inflammatory cells infiltrating the area, epithelial desquamation, which means the lining is shedding, and your mucus glands are literally going into overdrive. So that dry cough and scattered wheezing, that's simply air struggling to push through narrowed, swollen, mucus-filled branches. Section 3. The 3 stages of cough. Let's map out the timeline of this illness. The natural progression of this illness unfolds in a very predictable way. First, there's an initial upper respiratory phase. You know, the classic sneezing, runny nose, sore throat, hoarseness, maybe some mild fever and muscle aches. Then, the inflammation moves down into your chest, triggering the dry phase, a harsh, barking, irritating cough with that raw, burning feeling. Eventually, the wet phase kicks in as your body starts expectorating all that excess mucus. And here's the kicker. It can take up to a full 3 to 4 weeks for this whole process to completely resolve. Section 4, when it is not bronchitis. This is where we look for the dangerous mimics. So, how do we know it's not something worse? Well, simple bronchitis might give you scattered wheezes or a mild fever, but a serious mimic like pneumonia is going to announce itself loudly. If a clinician listens to your chest and hears diffuse, scattered sounds that clear up when you cough, that's pretty reassuring. But actually, if they tap on your chest and hear dullness to percussion, or listen and hear focal, localized crackles, or notice rapid breathing and low oxygen levels, the working diagnosis shifts immediately to pneumonia until proven otherwise. Think of these red flags as your personal detective checklist. Uncomplicated acute bronchitis doesn't cause confusion. It doesn't cause a resting heart rate over 100 beats per minute, that's tachycardia. And it certainly shouldn't cause you to cough up blood,
experience severe pleuritic chest pain, or suffer unexplained weight loss. If any of these warning signs are present, things like chest radiography and deeper diagnostic investigations are absolutely required right away. We also have to keep our eyes open for other clinical suspects. For instance, a cough that comes in violent, paroxysmal bursts followed by vomiting. That might be pertussis or whooping cough. Coughing up blood in an older patient with a smoking history demands an immediate evaluation to rule out lung cancer. And we can't forget the heart. An older patient with a sudden cough, swollen legs, and shortness of breath when lying down might actually be having a congestive heart failure exacerbation, not a respiratory infection at all. Context is literally everything here.
Section 5. The truth about antibiotics. It's time to bust some major medical myths. Okay, this is arguably the most pervasive myth in respiratory medicine. The assumption that a wet, colorful cough instantly demands antimicrobial firepower. We've all been conditioned to think that clear mucus means a virus, but green or yellow mucus automatically equals a bacterial infection. Sounds perfectly logical, right? Well, medically speaking, it is entirely false.
Antimicrobial stewardship is absolutely paramount here. The CDC, the National Institute for Health and Care Excellence, and the American College of Physicians all explicitly agree. Antibiotics are not recommended for uncomplicated acute bronchitis in stable adults, period. Antibiotics should strictly be reserved for suspected pneumonia, severe systemic illness, or frail patients with significant cardiopulmonary comorbidities. For the average healthy adult, taking an antibiotic might shorten a month-long cough by at best half a day, but it introduces huge risks of side effects and actively contributes to the global crisis of antibiotic resistance.
So what is that scary yellow or green mucus? It is literally just your body's immune cells doing their job. When your white blood cells fight off a virus, they die off and accumulate in your mucus. The color actually comes from a specific enzyme inside those dead white blood cells. It's just a visual sign of inflammation and your body's natural, totally normal cleanup process. It is not a distress signal for a bacterial invasion. Instead of rushing to medication, the modern medical consensus leans heavily on supportive care. Rest, maintain your hydration and nutrition, and fiercely avoid polluted air or tobacco smoke. You can use simple analgesics for aches or cautious, mild cough suppressants if the cough is severely disrupting your sleep. And note that bronchodilators like salbutamol shouldn't be used routinely unless the patient has underlying asthma or significant documented bronchospasm. The goal is to gently support the patient, not to completely suppress the cough. Because remember, that cough is your irritated airway's way of protecting itself. Section 6, Prevention and Key Takeaways. Let's see how we can avoid this ordeal entirely. Truly safe care and prevention start long before the cough ever begins. This means heavily emphasizing smoking cessation, sticking to basic respiratory hygiene and hand washing, and managing any chronic underlying diseases. On a population level, things like the annual flu vaccine and age-appropriate pneumococcal vaccines are game changers. They dramatically reduce your risk of catching those initial upper respiratory infections that cascade into acute bronchitis in the first place. Setting and managing expectations is absolutely critical. A healthy adult needs to understand from day one that this cough will likely linger for 3 to 4 weeks. Honestly, this might be the most important communication a clinician can have with a patient. If you expect a cough to vanish in 5 days, you're going to panic and demand antibiotics on day 10. But if you understand that post-infectious bronchial hyperresponsiveness keeps that airway twitchy and coughing for a month, you can rest easy knowing your body is simply taking the time it needs to heal naturally. It's a really powerful question to ask ourselves about how we advocate for our health, isn't it? It challenges us to rethink our heavy reliance on quick medical fixes when sometimes our bodies just need time and supportive care. We've mapped out the classic winter cough, we've identified the dangerous lookalikes, and we've successfully busted the colorful sputum myth. Keep an eye out for those red flags for sure, but otherwise, give your body the grace and the time it actually needs to recover. Thanks for exploring the science with me today on this explainer. Keep questioning, keep learning, and stay healthy out there.